and colleagues from around the world. Today, we have a special guest from Canada, hosted by Dr. Arash Hakemian. Her name, Dr. Fay Goldstep, with a tremendous resume and credentials and dedication to the profession of dentistry, spanning a career of many decades. Thank you for joining us, guys.
Thank you. Thank you for inviting us.
As of today, we have reached 530,000 plus of our colleagues from all over the world. And we are hoping to reach more and more as we finish the summit on May 31st. We aim to reach 1 million of our doctors and colleagues, our peers. And we are well on track. Please continue to share our vision and mission. And for CE and the doctor schedule, we have some very high-profile speakers coming up in the days to come. gi-summit.com. With that said, I would like to introduce Dr. Hakemian, our host today, from a family and generation of dentists. He has brought countless years of knowledge and information to our Board of Regents, as well as to the profession of dentistry, with his latest innovation that he's been working on for 3 years that happened to become a very, very important tool now for our colleagues, which is teledentistry. And you're welcome to, I'm sure you can miss Dr. Hakemian on social media. But with that said, thank you, Dr. Hakemian, for hosting this session. And with that said, you have the floor.
Very good. Yes, thank you so much for all our colleagues around the world. I am so excited about today's lecture. Actually, I cherry-picked speaking to Dr. Goldstep. Dr. Goldstep is an internationally recognized speaker on various topics, soft tissue lasers, electronic caries detection, bioactive dental materials, and much more. She served as a teaching mentor and as an educator in various universities, a contributing author to various textbooks. I think authored more than 100 articles. And Dr. Goldstep sits on the editorial board on the Oral Health Journal, the Dental Tribune, and Dental Asia. She is a consultant to several dental companies, and I believe maintains a private practice in Richmond Hill, Canada. Correct, doctor? You're still practicing?
Yes, still practicing in Richmond Hill, Canada, just a little bit north of Toronto. It's part of the Greater Toronto area.
Wonderful, and it's freezing there, I hear right now. It's pretty cold.
Yes, it's still cold. It's warming up next week, but we're still waiting. We're waiting and waiting for it to happen.
Now, I had the unique pleasure of meeting you and your husband in New York at the International Academy of Dental Facial Aesthetics, and it was a very amazing opportunity for me to meet such an esteemed group. And I think Gordon Christensen actually was the one who inducted me that year. So it was a memorable experience, and really amazing work you guys are doing, and really a pleasure and honor to speak to you today. And I know today you're speaking on the local systemic link of periodontal inflammation, correct?
Yes, I am. It's something that's very topical right now, and inflammation seems to be in the news every day. And I think I want to bring some insight into how dentists can get involved in breaking that link, basically.
Yeah, we hear year after year there's an increased link between periodontal disease and other systemic issues. And first it started with prostate, then obviously atherosclerosis and inflammation around the body, and then I think last year was huge, talking about the connection between Alzheimer's, I believe, and dementia. So I think it's a huge topic, and especially now when we want to keep our immune systems in tip-top shape, I think this is probably one of the most exactly. Well, with that said, I'll let you go ahead and begin your presentation, and really excited to hear all the information you have to share with us today.
Well, thank you very much. Thank you for inviting me. It's something that I'm really excited to share, and I hope I give you some insight, all of you, in some way that we can help decrease this link that can be so detrimental to our health, to our general health.
Perfect.
Okay, so let me start. Well, what is this? When I say the local systemic link, I think we're used to hearing the word also the oral systemic link, but it's actually a local systemic link, and I'm going to explain to you exactly how that works, and you'll see my thought processes, and I think it will help you in terms of helping your patients And I'm going to explain that link, and then afterwards I'm going to give you a couple of hints on how I work with breaking that link, breaking the origins of inflammation in the oral cavity. So let's start. So we know, as we see in this slide, there is a tremendous connection between patients who have systemic issues like diabetes, heart disease, and things like that, that will encourage them to have more periodontal disease. But we also hear and see and find out about a lot of evidence where periodontal disease can influence patients having more and more cardiovascular disease and other basically diseases, chronic diseases of aging. Now, I'm going to give you a bit of a background on how periodontal disease originates, what happens, and then seeing how that happens, how the connection occurs between the periodontal disease at the local level in the oral cavity, and how that progresses to periodontal disease and systemic disease, first periodontal disease, and then all these systemic diseases throughout the body. So we know that periodontal disease is an inflammatory disease, but it starts as a biofilm associated inflammatory disease. So there are several aspects to it. It's not just a one-shot idea. It's not just the biofilm. In the past, we thought, okay, bacteria starts it. As soon as we get rid of the bacteria, we're free and clear. But that's not always the case. Sometimes other things occur. There is a cascade reaction, and that's what we're going to discuss right now. How does that cascade happen? How can we break it? What can we do? So, as I said, originally we thought it's all about the bacteria. Removing biofilm, getting rid of this etiological agent. But then a lot of times when we remove the etiological agent, we find out that that is not enough. Not only that, we have patients who have quite a fair amount of plaque, and yet they still have periodontal disease. So what's up with all this? What is causing all this? Why is it bacteria? The bacteria can start it, and what happens afterwards? So it's all about bacteria, but not totally. It is sort of about the bacteria. So I'm going to start with a little bit of an explanation on how periodontal disease starts up, and a bit of a simplification of periodontal inflammation. I think right now, when we're stuck at home reading a lot about COVID-19, we're learning a lot about inflammation, virology, and all these other things. So I think many of us are becoming more experts on inflammation, but it's also important for us to know the etiology, especially when it comes to the area we're so interested in, and that's the oral cavity. So the story so far is there is a bacterial stimulus, of course, the plaque, the biofilm in the oral cavity, that creates a cascade response. Now, this cascade response is first an innate and then adaptive response. Now, what we mean about the innate response is that it's something that happens very easily and early in a person's life. When they have inflammation, it just attacks anything that's foreign. Now, if we have innate response, it has to be actively resolved to create health. If it goes off and continues, then we have more disease. We have inflammatory disease. And we also know that inflammatory disease and inflammation is affected by many multiple risk factors, including genetics. And the two problems are when we have an overexpression of inflammation, that can develop and create a progression of diseases of aging. An underexpression of inflammation is also an issue. So you don't want overexpression of inflammation, and you don't want to have patients that don't have enough inflammation to stop the disease process. So periodontal disease treatment must take into the account the inflammatory component as well as the original bacterial stimulus. So as I said, the innate response is something that comes to people very early in their lives. It's something that's non-specific. It's the attack of the healthy periodontium to eliminate the foreign bodies, and it protects against injury and infection. This is a very protective situation. This is helping us. We always hear inflammation is bad. Inflammation is not bad at all. Inflammation is a good response. It's something that's very healthy. But it's when it goes for too long and it's not resolved in a healthy manner, that's when we have an issue. So what is the sequence? The sequence is we have blood vessels that dilate, increasing the blood flow. Then you have these white blood cells, which are called neutrophils, that are dispatched to the site, and also macrophages, which just do a lot of chomping and eat up all the debris. So they're dispatched to the area of inflammation. Now, they release something called cytokines. Now, we're hearing a lot about cytokines in the news about COVID as well, because we know that the cytokine storm is an issue. So if too many of these these cytokines or these bioactive protein cell communicators, if they're released, then there's a problem. So cytokines are just, as I said, bioactive protein cell communicators. They give the information, send the information from place to place. They're secreted by these white blood cells, by these neutrophils, and they regulate how the body responds locally as well as systemically. And we know that the immune cells, like neutrophils and macrophages, and the cytokines attempt to destroy and dilute or wall off all these injurious agents that are coming in, these foreign bodies that are coming in. So what is the healthy, beneficial inflammatory response? Remember I said inflammation is healthy. It is beneficial. It's only when it goes too far that it is not. So the acute response, the response of the body initially to help resolve inflammation, resolve the issue, resolve this foreign body that get rid of the foreign body that's attacking. This is a response that takes place in the periodontal tissues, on the cellular level, and in the biochemical level. So I'm going to go over inflammation. Now, I'm trying to make this as simple as possible, but just bear with me going over how this is. Remember, we've got the periodontal tissues, and they release cells. And these cells release biochemicals. So it's all taking place. What we see as dentists is the periodontal tissue. We don't see the cells, and we certainly do not see the biochemical level of action. So what we see is something that's visible to us as we look at our patients, and that is vascular dilation, increased permeability of capillaries, and increased blood flow. Basically, we see that as inflamed tissue, red, bulbous tissue, which can bleed very easily. And while this is happening, this will be at the gingivitis stage. While this is happening, the cells themselves they're in the crevicular fluid, and the crevicular fluid contains neutrophils, macrophages, and a lot of other cells. And these are the cells that secrete those cytokines that we keep hearing about. And these cytokines are the ones that regulate the inflammatory response. Now, these cytokines have very elaborate names. There's a lot of Greek letters in there and numbers and regular letters. So I try to avoid the actual naming of these cytokines. I may show you a couple of them and mention a couple of them later on in the presentation. But just know that these are the cells that regulate the inflammatory response. Too few cytokines that's a problem, and too many cytokines create the cytokine storm that is also a problem. Now, at a biochemical level, the neutrophils, the cytokines will encourage the delivery of something called arachidonic acid. That's released primarily by the neutrophils, and that produces prostaglandin. And we all know that prostaglandin can cause bone resorption in periodontal disease. So here we see the plaque, and we see bacteria that is forming, and we see the plaque is causing bacteria to break off and cause issues in the crevicular fluid. We have macrophages that are formed, that are in the in the inflamed tissue, and neutrophils, those are the white blood cells, and they are releasing cytokines and also arachidonic acid, which encourages the formation of prostaglandin, which can start breaking down the tissue. So what do we need for the active resolution of the acute response? Remember, only when you have resolution will you have health. This is supposed to be a short-term solution. Inflammation is not made to be around for a long period of time. For active resolution, we need the bacterial stimulus to be removed. So we need to get rid of the bacteria. On a cellular level, we see that the crevicular fluid is going to now have fewer neutrophils, fewer macrophages, and only remnants of bacteria. They're not in full force anymore. On the biochemical level, the arachidonic acid, which was a positive material, which was a negative material before, and it was released by the neutrophils, now starts to produce lipoxin. Now, lipoxin is a material which is a very good material that stops and resolves inflammatory response. So there's almost a switch is turned on where the arachidonic acid will no longer produce prostaglandin, but starts to produce the lipoxins. And we all hear about omega-3s being positive. Here's where omega-3s also have an aspect, and they're helpful. They're helpful because they produce something called resolvin, and resolvin is something that they create resolve. The dietary omega-3s produce resolvin, and that also helps actively resolve. And resolvin is something that they create resolve. The dietary omega-3s produce resolvin, and that also helps. Now here we've got the situation where things are being resolved. We have the neutrophils. There are fewer neutrophils. They are releasing the arachidonic acid, which is now releasing lipoxin, which is a positive thing. It's going to resolve inflammation. And the omega-3s, which we have in our diet, will start to resolve which they also release something called resolvin. So omega-3s release resolvins that stop and resolve the initial inflammation, and the neutrophils will release arachidonic acid, which produces lipoxin that also resolves the situation. So we have two parallel pathways to resolve inflammation. This is the positive, beneficial, acute inflammatory response. This is where it should stop. Unfortunately, that doesn't happen always. So this healthy, beneficial inflammatory response returns the patient to health. We know a lot of patients who may have some areas of slight gingivitis, and they brush and they clean and all that. And these are healthy patients, and they will resolve and return to health very easily. But what happens when this goes haywire? Here we have the positive response, and this is where we should be. So when it does go haywire, we have something called the chronic maladaptive inflammatory response. And remember I said that these cytokines have lots of different letters and numbers and Greek letters to their name. Here's one with the name IL-1 beta. So we know that different pathogens will trigger the chronic inflammatory response and release these cytokines like IL-1B. So the chronic inflammatory response drives the connective tissue to bone loss and loss of connective tissue as well. That is what we call chronic inflammation. We want to stop it at the acute beneficial stage. When it goes chronic, it is no longer beneficial. Then it actually becomes a disease itself. So when we have it as a disease itself, what is going on is we have cellular and molecular responses to bacterial challenge, and they have a constant feedback and adjustment Here, the neutrophils and macrophages continue to secrete the cytokines. That it's not resolved at all. Those resolvins and lipoxins have not worked to stop it. So we now have this chronic lesion and periodontal destruction. The cytokines continue to promote something called MMPs, and that is something that includes collagenase. And you know, when you have the last three letters of ASE, it means something that's breaking it down. Collagenase is something that breaks down collagen. So these cytokines are starting to produce and promote the release of this collagenase, which breaks down collagen, and also prostaglandin, which breaks down bone. This tissue destruction constantly is adjusted by the host, which is the body itself, and the bacterial interaction. Some hosts or bodies don't promote the stopping of the acute infection. So we have the bacterial etiology, but it's how the body responds that causes it to be an issue. When you have a deficient host response, you usually initiate the chronic condition, and then sometimes the vigorous host response leads to further tissue breakdown. So it can be a problem when it's deficient, and it can be a problem when it's too robust, too vigorous. You don't want either. You want it to be, there should be a certain balance, and we know that balance is good in health in general, but definitely in terms of inflammation, we don't want to have a great inflammatory bacterial burden, which causes infection, and we also don't want a inflammatory burden, which causes sustained chronic inflammation. So here we have the continuation of inflammation in the chronic state. Here we still have a lot of plaque, and the plaque is releasing bacteria into the pocket. We have macrophages that are trying to desperately break down the bacteria. We have the neutrophils releasing cytokines, which promote the release of MMPs. Remember the collagenases. And the arachidonic acid, which was benevolent when it released lipoxins, is now releasing prostaglandins that are breaking down the bone. As you can see, the bone level is decreasing quite significantly. And you can see there's a lot of negative interactions here. Things are becoming chronic, and this is where disease is a lot more severe. So in the late chronic lesion, what's going on? We can see what's going on in the periodontal tissue because we can observe that. We can see, well, we can't see the apical migration of pathogenic bacteria, but we assume that's there. But we can see the periodontal ligament breakdown because we can see the pockets are getting larger. We can also see the ulceration of the epithelial lining because that's causing bleeding. And we know that the bone level is becoming resorbed. We can see that visually, and we can see that as well on our x-rays. On the cellular level, there is the increased neutrophil. There are increased neutrophils in the pocket, macrophages, etc., and other detrimental, or which were once positive cells that help with original inflammation and now are becoming detrimental. And on the biochemical level, this is where most of the detriment is happening. We have the increased pro-inflammatory cytokine activity. And interestingly enough, this is a self-fulfilling prophecy, and it's going round and round. What's happening is the collagen fragments are providing nutrition for bacteria. So they're having a field day. They're having a big party in the pocket because they're eating up all those lovely collagen fragments that are occurring because of the inflammation and the breakdown because of collagenase. So all this collagen is causing things to just get worse and worse, and it becomes a self-fulfilling situation. So here we can see more plaque, more destruction. The periodontal ligament is getting destroyed. The collagen is being removed. More cytokine activity, greater neutrophil response, macrophages, and the arachidonic acid is still producing the prostaglandin, which is causing more bone loss. The osteoclasts are also having a field day. So how does that connect with the body? Remember, I said it was a local systemic link. I was careful not to call it the oral systemic link, because actually this is going on in all sorts of areas in the body. Patients that have issues with their liver, their kidneys, their brain, and all these, there may be inflammation in those areas too. And there may be problems in those areas too. So areas where you are vulnerable, that's where you're going to have your issues, whether it's in the pancreas with somebody with diabetes, or in the brain with somebody that's going to develop Alzheimer's, or in the heart for cardiovascular disease. We all have areas where we're vulnerable, and we have a possibility that if the inflammatory burden goes a little haywire, goes a little bit too much, that's where we're going to suffer. So it's not necessarily just oral systemic, it's local systemic. This area, this local area, which started off with bacteria and then becomes a problem, an inflammatory problem, is causing all sorts of things to happen. You can see on this screen what's going on. I'll go over it in the next slide, and then we'll come back to this slide again. So what exactly is going on? What is the local systemic link from the oral cavity to the rest of the body? Okay, number one, we've got the ulcerations of pocket epithelium in the periodontal pocket. That promotes a risk for distant site infection and transient bacteremia. So that can stay in the pocket itself or can go somewhere else. And the cytokines that are produced in the pocket can actually work systemically. So all these cytokines that are working locally in the oral cavity are also going to other organ systems. So they're creating an inflammatory burden in other areas. This organ system can be lots of different things. As you can see in number 4, the cytokines can affect arteries and organs. They can also affect any organ where you have a problem, whether it's the brain, the heart, the liver, all of these things. So in number 3, we have the bacterial diffusion from the local area can release molecules to other areas and trigger a remote inflammatory response. So you could have the local in the area that we were talking about, the periodontal pocket, but the bacteria can diffuse and go to other areas and cause inflammation in other areas as well. This, as I mentioned, the circulating cytokines can affect arteries and organs, and the circulating cytokines can induce problems in the liver, and that is mostly creating something called C-reactive protein. You may have heard of C-reactive protein as a biomarker for inflammation. And that C-reactive protein will also cause injuries to organs, leading to cardiovascular disease and strokes. So all of that is interconnected. It started off simply as too much plaque or bacteria that are in the oral cavity, and that started the initial response. But see how it became more of a systemic response. So we'll show you again on this beautiful illustration. You can see in the pockets, we have a local reaction, but those individual cytokines can actually directly affect organs like the heart, like the liver, like the brain, directly from the periodontal pocket, or the bacteria can go to other areas and cause an inflammatory response, and thereby also releasing cytokines there that can cause problems. And the cytokines will work on the liver to release C-reactive protein, which itself is a biomarker for inflammation, and that can cause more cardiovascular disease. So it's all interconnected. All of this is causing a dramatic response in the body, and wherever you're vulnerable is where you're going to feel this excess inflammatory burden. So the local systemic link, the pathways of action, the way it can be explained is that periodontal disease is a significant contributor to the total inflammatory burden on the body and can adversely affect the entire system, the body's entire systemic health. So, and that can happen in all sorts of different areas. The relationship the periodontal disease is very strong, and there have been lots of studies that show how it affects chronic inflammatory diseases of aging, such as cardiovascular disease, arthritis, Alzheimer's, diabetes, and many cancers. So what we have to do as oral care providers is to stop this link if we can. I mean, other healthcare providers will work on stopping the link in other areas, but we must stop it in the periodontal pocket and stop inflammation in the oral cavity. How can we do that? There are many ways. I've chosen to work on a couple of different ways. One of them is simply an oral hygiene technique, which I find is the most effective for my patients. And that's the first one I'll discuss. And the second one is a very high-tech technique. So we're going to go from one extreme to the other, but both can help stop that link, control that, and break the local systemic link. So we know that in terms of oral hygiene solutions, there are many different oral hygiene solutions. We want to control the biofilm in gingivitis that initiates the local systemic link. That can be done through flossing, interdental brushes, or water flossing. There are many different ways to improve gingival health. There have been a couple of studies. This was a very good study that was done in 2018, and it was a meta-analysis of interproximal oral hygiene methods. So we're talking interproximal methods. So not just brushing, we're talking about interproximal areas. So the meta-analysis of the interproximal oral hygiene methods in the reduction of clinical indices of inflammation. So they studied different products, and this was for individuals physically able to perform oral hygiene tasks. Of course, we have a lot of people who are not able to perform that, but for the average person who can perform oral hygiene tasks, will any specific means of interproximal tooth cleaning lead to a greater reduction in plaque accumulation, gingival inflammation, and pocket depth reduction in comparison to other means of interproximal tooth cleaning or toothbrushing alone? That was the question that was asked. And here were the answers. So this analysis showed that the highest probability of being the best for reduction of the gingival index would either be interdental brushes or the water flosser. The probability for floss or wood sticks was next to zero. So that's I think, very interesting. I've been suggesting water flossing for a very, very long time, and that's what I use myself for my oral hygiene method of choice. And I'll go over why that is in the next few slides. So in terms of interdental brushes, though, there was another study in 2013 that showed that the problem was that there is a need for a variety of shapes and sizes to accommodate different embrasures. And that is why I highly recommend the water flosser, because it is indicated for every situation. It's used for customized oral hygiene solutions. Basically, if a patient has implants, a patient has orthodontic appliances, or anything like that, this is basically, it's not a one-size-fits-all, but it fits all sizes because it's a customized oral hygiene solution for every indication. So I'm not sure whether I can get this video to work. No, we can't get the video to work, but that's fine. Basically, this shows the power washing capabilities of the water flosser on a piece of corn on the cob. You can try this yourself, but this is a great way of showing this. It has been demonstrated at medium pressure and above, it's safe to use on all settings. And the reason is it's the pulsation and the pressure that creates compression and decompression phase. It permits the tissue to expel debris and bacteria up to 6 millimeters. So you can actually get up to 6 millimeters. You can go into the pocket up to 6 millimeters and remove what's there. And I will show you, this is just to remove the bacteria and the plaque. Later on, I'm actually going to show you some studies that showed how it can stop the inflammatory response as well by working on the cytokines, which is very dramatic and a lot more exciting than just removing bacteria. Bacteria is great. Being able to remove plaque and bacteria is wonderful, but if you can also help the host inflammatory response, this is where the message is, and this is where the greatness of the product is. Okay, so as I was saying about water flossing, there have been many studies. Actually, water flossing has been around for over 55 years. And there have been many, many studies on it. The most important studies were there was a study comparing it to string floss, which is the regular floss that we talk about as being floss. And that was showing that water flossing was 50% more effective for reducing gingivitis, 29% better for plaque removal, 3 times as effective for string floss as string floss for orthodontic cases. Remember, I said customizing is the best, and it's great for ortho because you can't use floss for ortho unless you're going to use those big gorilla floss and all the different things that you use underneath, which nobody really uses because it's too difficult to use. And it's great for implants. I'm going to be showing you some pictures of what happens when you use a floss around implants, and it's frightening. There are pieces of floss that are left around the implant. That shocked me when I saw it. There have been studies, and I'll show you that study quite soon. Okay, so let's go to our next slide. Okay, so we know that water flossing is clinically proven to remove plaque. You can see on the left screen, on the left side, pre-treatment with plaque biofilm, and then afterwards you have the plaque removed with the jet tip of the water flosser. And also, we were talking about interdental brushes being pretty good for cleaning between teeth. Remember that original study that I was showing you? But here you can see that the water flosser was way more effective in improving gingival health only after just 2 weeks. And it was 56% more effective improving gingival health and 20% more effective at removing interproximal plaque after a single visit. Because, as I said, it's a power washer. And what should have been shown on that video was how it power washes through the kernels of corn, because it's the only thing that can actually get into and in between, and it's perfectly safe at the pressure that it's used at. So here is what I think is really mind-blowing, how it acts around implants. So it can be used with water at a medium setting, and it's very effective. On this video, you could see that it would remove all the plaque around the implant. But what's even more interesting is this is the study that I was talking about, and basically there was an observational study of 10 cases. There were patients that had progressive periimplantitis, and nobody knew why. And they followed an intensive oral hygiene protocol, but they weren't getting any better. So what was found is they had remnants of dental floss that were found around the neck and coronal part of the dental implant. And after that floss was removed, there was significant improvement around and no periimplantitis. And then they did a secondary in vitro examination that shows how when you put a floss in between teeth, even on a model, you end up with the floss inside the implant. I mean, the floss will stay on the implant and the wax will be on the implant. So you're keeping that for a long period of time. And that's something the body can't eliminate. So that's where the problem arises. So they had these patients who had progressive periodontitis, non-responsive to therapy. When they removed the floss, 9 out of the 10 cases resolved. And then when they had the follow-up in the lab, you can see here, a pristine implant was exposed to floss, and afterwards there was the evidence of fiber and wax around the implant after the floss had been used. Now, this is what the fibers look like. These are the fibers that were removed from the cases. And it's amazing that it stays underneath and traps plaque. And if you use floss around an implant, that's what you're using around the implant. That's what's going to stay there. And that could definitely encourage periimplantitis. So you should not be using floss around implants. Here's another case. Remember, we were talking about how water flossing not only removes bacteria, But this is an excellent article that was done showing how effective the water flossing was compared to an antibiotic. So it was more than it was as effective as an antibiotic, and I'll show you in the next slide how it's actually anti-inflammatory as well. So we all know minocycline, which is Arestin. So subjects with moderate to severe periodontal disease received scaling and root planing, and then were either given minocycline, Arestin, at the scaling and root planing visit, or were told to use the water flosser for 30 days. After 30 days, both treatment groups had significant improvement in bleeding, pocket depth, and clinical attachment. And the differences between the groups were not statistically significant. So would you not want to, on your own self or on your patient or your family member, to use something like a water flosser as opposed to using an antibiotic? I think it's self-evident that obviously you'd rather use something like the water flosser. And what about host modulation? Here is where the proof is in the pudding in terms of inflammatory response. This study showed the clinical benefits of oral irrigation, water flossing, for periodontitis that is related to reduction of pro-inflammatory cytokine levels. So using the water flosser, patients were given, their cytokine level was measured after using the water flosser, and after 14 days, they had decreased levels of IL-1 beta that we discussed before, and PGE2. And the increase in the IL-10, that's a beneficial cytokine. Of course, there are beneficial and negative cytokines. So oral irrigation for 14 days had an improved therapeutic benefit for periodontitis over routine oral hygiene alone. And this improvement was accompanied by down modulation of pro-inflammatory cytokines. That is huge. That was in the gingival auricular fluid. So it is amazing that something, probably the pressure of the water flosser, just that pressure does the modulation of down modulation of the cytokine level. And they had another study on the same kind of idea of using water flossing, but here it was on diabetics. And the water flosser had a statistically significant reduction in gingival inflammation, periodontal effects, bleeding on probing, and other things. Reactive oxygen species also is a biomarker for inflammation. So reactive oxygen species compared to controls. There was also reduction of other inflammatory cytokines. So we're seeing that water flossing can remove bacteria, but can also help the host fight the inflammatory burden as well. So that's why this is my go-to in terms of hygiene care for my patients. And also, I go back here actually, I'm not going to show the video, but a pickpocket is a way of getting the medicament into pockets and for patients with a smaller tip that actually goes right into the medication and delivers the medication where it needs to be. And remember, I said that it was a customizable way of dealing with patients' needs. We have the classic tip for general use. We've got an orthodontic tip for patients that are undergoing orthodontic therapy. The tip would be for people that have implants because it can go around and actually it's a little brush as well. And the pickpocket can release medicaments into the areas where it's needed. So it's definitely customizable for individual patient needs. They also now have something where they use where you can brush and floss at the same time. That's the new Sonic Fusion that was just released, I think about a year ago. So basically, this is my first go-to method on how to break the local systemic link, because we have biofilm control, removal, very efficient removal of bacteria, at least as efficient as an antibiotic like Arestin. Host modulation of inflammation. There's great diabetic data that improves diabetic outcomes. access to hard to reach areas. It keeps it simple, again, customizable for every oral hygiene solution. So this would be the oral hygiene solution for breaking the local systemic link. What about something that's more dramatic, something that we can use in our offices? This is something that I've been using for many years. When the diode laser became affordable and usable and user-friendly, I wrote a whole slew of articles on diode laser, where have you been all my life? Because it was just a miracle for me, because that, again, was something that could treat my patients in a very healthful, healing way. So I got very excited and did a little bit of dance here. Okay, so this is great for laser healing procedures. The soft tissue diode laser has surgical precision, bloodless. It sterilizes the surgical sites, minimal swelling and scarring. It can helps with coagulation and vaporization, and it uses minimal or no suturing. It's basically healing as it goes. So you're sterilizing the areas. You're doing all sorts of good things to it when you're using it for the therapies. But what about using it for periodontal healing? Also, I forgot to mention, this is actually one of the most important reasons. If there's decreased or no pain involved, much less painful than any other solution in terms of periodontal treatment. So what is laser-assisted periodontal therapy? We go from situation on the left to the situation on the right. Why does it help? What is the reason? I always like to know why. You see how I analyzed why the water flosser is so great. I want to know why the diode laser is so great. Why is it so helpful in terms of periodontal therapy? For 3 reasons. Biostimulation, and we'll go over all these 3 in a moment, one after the other. Biostimulation, it actually doesn't just remove bacteria, it biostimulates. Again, working on the inflammatory response and helping the host fight off a bad inflammatory response and bring great balance to the inflammatory response. So it also helps with decontamination of bacteria and bacterial reduction. And it helps with soft tissue curettage. This is a trifecta of why the diode laser helps in laser healing procedures. So let's start with biostimulation. When a laser is used, we have light photons that are absorbed by the mitochondria. You can see the mitochondria on the cell above, on the right over there, if you remember from your cellular biology many years ago. So the light photons are absorbed by the mitochondria, and that stimulates cellular energy. We have the restoration, we stimulate a number of the restoration of cell morphology after the cell is acted upon. So we have whatever the cell needs. You act upon the cell, but while you're acting upon the cell, either you're cutting or you're doing whatever you're doing in curettage or whatever you're doing, not only are you doing that effect, you're also stimulating a number of secondary effects. Okay, so let me just go back to that. So all these secondary clinical effects are helpful. So we are whatever the laser does for you, your clinical action that you need, whether you're cutting something, removing an operculum, or whatever you're doing that effect, but you're also creating all these secondary benefits: collagen synthesis, blood vessel production, stimulation of osteoblasts and odontoblasts, decreasing all these histamines and bradykinins. So you're getting good wound healing, good bone indentation formation, and decreasing inflammation and pain. So that is the biostimulation effect. So whenever you do something with a laser, you're going to have biostimulation. All these secondary effects as extra effects. You know, usually we have bad effects from medications, negative effects. Here we have positive effects from the laser constantly. So surgical versus therapeutic. Usually with a surgical laser, you're just cutting, so it's a very narrow beam. Whereas with a therapeutic, it's a wide area, much more therapeutic, a wide area, which the beam size for the surgical is much narrower, and for the therapeutic is wider. and I'll explain how that happens in the next slide. This is where the biostimulation happens. In the center, you have vaporization. Around that, you've got carbonization. Around that, there's coagulation. Around that, you're denaturing the proteins. And around that, you've got the photothermic effect. And around that, the photostimulating effect. So around the area that you're working on, you're always going to have a photostimulating effect. That is what's going on. Those are the secondary positive benefits of the diode laser. So that's one of the reasons it helps with periodontal therapy, because of the photostimulation. The second thing that we mentioned was decontamination. We decontaminate because the soft tissue diode laser is bactericidal. And it suppresses these aggressive peripathogens that are very deep in the pocket. So it's not just going to kill things at a superficial level, it goes deep into the pocket. It's stimulating as well as removing these peripathogens. If you were going to try to get rid of those peripathogens, you'd have to rip apart the periodontal ligament and get into that area. But with the diode laser, it goes in there with the light source and it removes those peripathogens, and it's a long-lasting effect. So you decontaminate by going into the pocket and focusing the beam and getting the beam down into the pocket. And so the first one is biostimulation. The second is removing the bacteria. The third is gingival curettage. We want to get rid of the bits and pieces and the dirt that's in there. That has to be removed as well. And how do we do that? Well, this is a very, upsetting statement from the American Academy of Periodontology, which came out in 2002, that said gingival curettage, by whatever method performed, should be considered as a procedure that has no additional benefit to scaling and root planing alone in the treatment of chronic periodontitis. All the methods devised for curettage have the same goal, which is the complete removal of the epithelium. None of these alternative methods has a clinical or microbial advantage over the mechanical instrumentation with a curette. That's baloney, because we know for a fact that the laser is very beneficial in this area. And why is it so beneficial? Because it's well absorbed by melanin and hemoglobin. That basically the laser light goes into the pocket. It's absorbed by melanin and hemoglobin. What do you think is very there? What do we have a lot of in those pockets? A lot of melanin and a lot of hemoglobin, because it's darker because of a lot of blood from the hemoglobin. The hemoglobin will be from the blood, and also dark color from the blood. So specifically targets unhealthy gingiva. Well absorbed and specifically targets healthy gingiva. So that statement about it not being more beneficial is hogwash. And the fiber can penetrate very deep into the pocket. And that way it completely removes the pocket epithelium. If you try to remove the pocket epithelium with a curette easily, you're going to get little bits and pieces. It completely removes the pocket epithelium. So you have to eliminate and have a clean surface and get rid of the calculus first, of course. But afterwards, after scaling and root planing, then you can go ahead and do your laser periodontal treatment. When it's used as an adjunct to scaling and root planing, the studies have shown that there's decreased bleeding, inflammation, and pocket depth, decreased tooth mobility, improvements are stable, and the patient comfort is definitely enhanced post-op. So the protocol would be first to check to see how deep the pockets are, do the scaling and root planing, so we've got a nice clean surface, and then fire up your laser at 0.6 to 1 watt continuous is what I use. The video we're not going to try. After we do that, we have a nice clean surface, and then healing can take place. We use a biostimulating tip afterwards to add biostimulation. First was more of a surgical tip, and this is a biostimulatory tip, which adds more biostimulation. And we check the pockets again in 3 months. And this is what graphically we can hope to find after 3 months. Before and after. It's safe and effective. We know that there's no alteration to root structure or cementum, no thermal side effects, no adverse tissue events, decreased need for antibiotics, very important. There's biostimulation, bacterial reduction. You've got hemostasis, much easier visibility than having blood all over the place, because you're using curettes, you're going to get a lot more bleeding. This is nice and clean. Way improved healing, enhanced comfort for the patients, and patients love it because it's a high-tech system. So we have the means to break the link. And I hope with it, what I've explained to you, I've explained the link to you. What is the oral, what they call the oral, but I call the local systemic link in the body between periodontal health and systemic health, and how, and a couple of systems that I use in my practice, oral hygiene systems, like the water flosser, which I use for all my patients, and the periodontal treatment through laser periodontal therapy. Thank you.
Wonderful. Thank you so much, Dr. Goldstep. That was amazing. And I have a couple of follow-up questions, if I may. So
sure.
One of the points you were mentioning about the pulsation and the massaging action on the gums being helpful. And I recently saw a device a couple of months ago that it kind of molds and is like a mouthpiece that actually goes around the teeth and the gums, and through pulsation of air actually causes that similar massaging and pulsation action. What are your thoughts on something like that?
I've seen similar things, but there haven't been as many studies. This is 55 years worth of studies on the water flossing. This looks interesting, especially for patients who can't manipulate water flossing. It might be an interesting way of going about it. But I think in terms of science and the background and the studies that have been done on water flossing, that's still my go-to.
And I have two other questions, actually. So I've personally been using sodium hypochlorite, a diluted bleach combination, 1 part water, 1 part bleach, 20 parts water. And what are your thoughts about sodium hypochlorite being used in rinses? Is that something that you recommend? You don't recommend?
I don't. In terms of the water flosser, actually, there have been studies using different solutions in the water flossing. But water actually is usually the best, and they've had so many studies just using water. You can use chlorhexidine and all these other materials as well. I think there are, I actually know of a couple of different solutions that are coming out in the next little while that might be even more exciting. I'm not crazy about using sodium hypochlorite. Anything I'm using in an endodontic situation, I'm not using getting into my body, into my pockets. So personally, I wouldn't want it in my mouth, but that's fine. I mean, I know people do use it.
And how about hydrogen peroxide? So now we're being advised that hydrogen peroxide really helps with killing the coronavirus. What are your thoughts on hydrogen peroxide use?
I think hydrogen peroxide is probably a good idea too. And again, hydrogen peroxide is not as innocuous as a lot of new as something that I think is coming soon. And I probably will be able to tell you about that in the near future. I know there are a lot of studies now with hydrogen peroxide because of coronavirus, and everybody's talking about that. But it's still not as innocuous and not as beneficial. There's actually something coming up very shortly, which has you can actually drink it, and it has antiviral effects. So be posted on this. It's coming out very soon because of the interest, because of coronavirus, and everybody's worried about coronavirus. There are studies that are going on right now to check it against viral load and all these different things. So something that's very exciting, very beneficial, not hydrogen peroxide, which is not a bad material, but it's still not something you would drink.
Okay, wonderful. Yeah, and I think another thing that a lot of patients have been asking me over the last 2 years, all of a sudden there's a fad called oil pulling, is swishing around coconut oil. Have you heard of this?
I'm not big on fads, and they also had there's so many different things. They had carbon things coming off charcoal, and that was big, and now that's not
Right.
big anymore. Same idea, the goopy stuff from Gwyneth Paltrow. I don't follow any of that stuff. I'm not big on followers and stuff. Whatever's tried and true. I'm not only like it has to be scientifically based. I'm not against things that are alternative possibilities, but there still have to be some studies on them. I'm happy with things that are natural and that kind of stuff. But most of these things are, overkill, like snake oil. A lot of these things are snake oils.
I see. And how about some of these perio programs where they create suck down and actually have the ability to put different types of medicaments inside these suck downs and allow them to have more contact absorption time?
I think that's good. That's another possibility. That is not a bad idea. I've seen that too, like Perio Protect. That's probably
Right.
a good thing as well. Yeah, there are lots of different ways. I just wanted to show you two different ways. One was at the beginning of the cycle, which would be the oral hygiene solution, which for me the best solution is water flossing. And then the other extreme would be the laser. But in between, there are lots of different aspects that can be used. It doesn't mean this is the only stuff, but for oral hygiene, I would use that. And for my go-to oral hygiene, I'd go for water flossing, and my go-to for periodontal treatment would be the laser.
Yeah, especially given these current times, I think hygiene is going to be really, really a instrumental way for us to be able to maintain our patients over the next 6 months. I know a lot of hygienists are worried about coming back. Patients haven't been receiving cleanings for several months.
Right.
Yeah,
And
I'm
they're
excited
due.
to see exactly what. Right, exactly. Overdue.
They're way overdue.
I think. Go ahead.
It'll take
Yes.
some time to get people to come back. They will come back. And again, because there will be solutions like the one I mentioned that will possibly help in terms of having, I think pre-rinsing prior to having anything done has to be the new normal, and will be the new normal, not just for a short period of time. Right now with coronavirus, I think right now we're not normal. Now we're getting to like different stages of new normal, but then permanently, for the permanent new normal, you probably should have some sort of rinse prior to doing hygiene appointments or any appointment. It's such an easy thing to do. That way you're going to get rid of the bacterial load. And as I said, this material that's coming out soon will be able to do that in a natural, beneficial way.
Wonderful. Yeah, I think it's going to be really key and really important for us as dentists to understand the inflammatory process and how really this is going to affect our patients moving forward, especially with the given connections between the systemic health and the oral health, and really making sure that our immune systems are really working to their full capacity without having this localized, well, now it's no longer localized, now it's systemic.
Right. Well, it's not, they used to call it oral systemic. I say local systemic. So it is break that local reaction that goes to become a systemic reaction. And we need to break that. We can.
I never knew. I've placed probably over 1,000 implants, and I never knew that the floss can actually stick around the threads of the implant. And so
it was shocking when I first saw that last year. I was shocked.
Unbelievable. How about proxy brushes? Any experience with?
I don't think proxy brushes are as bad. I won't think of it as bad. The fibers don't come off as easily, but just think of it. It's a thread. Threads just come apart.
Right.
And the wax will stay off. It will come off too, especially if it's wax. The wax and the fibers will come off. So definitely for everybody that, like, as soon as I saw that, I said, none of my patients none of them can have that. They cannot use floss around an implant.
Yeah, every single one of my implant patient leaves with a water pick or some type of a water flosser, and that's just standard protocol in our office. But I also heavily emphasize flossing and using proxy brushes. So I think that's really, really great information. We really appreciate you taking the time to share this wonderful information with us today. I hope to see you guys again. I'm looking forward to next year in New York and seeing you.
We're looking forward to it too, very much.
it's such a great time and great people in your organization. And once again, we thank you. I want to thank Dr. Keonor Shaw and the Global Interdisciplinary Summit. We've had over 500,000 views in such a short period of time, and it's amazing to see our wonderful doctors from across the planet come together on this peer-to-peer network and really share amazing information. So thank you, Dr. Shaw, and thank you for your organization for putting this together. And thank you so much again, Dr. Goldstep, for joining us today. Where can people reach you if you have any further questions? What's your contact information where people can reach you?
Oh, you can reach me at Goldstep at epdot.com.
Goldstep at eptod.com.
E like England, P like Peter, D like David, O like Omaha, T like Toronto.com. Goldstep at epdot.com.
Wonderful. All right. With that, I'll let you take it over, Dr. Shaw.
Thank you so much for everything today, for your contribution to this project. We wish you guys a wonderful week that is ahead of us. And I look forward to seeing you at a future event. With that said, if you have additional questions for Dr. Goldstep, you can leave them in the comment section below, and we will attend to them in a timely fashion. Thank you so much, and have a great day, guys.
Thank you.
Thank you
Bye.
so much. Stay healthy.